Hello YouTube family. This is in contribution to the prior presentation pharmacology overview that I did previously. There will be continuation of this one as well. So first we're going to go over controlled substance management. So the first thing, we want to secure all controlled substance. They are stored in a locked container requiring key or code access. An inventory record of all controlled substance is used and maintained in all healthcare facility. When witnessing disposal of any part of a disposed controlled substance that is to be discarded, we as nurses should know that a second nurse must be witnessing this disposal. The record or the inventory sheet must also be signed off by the second nurse. It's just very important that you identify with your agency policies and procedures and always follow them when it comes to the handling of controlled substance. Agency policies and procedure are followed with regard to counting of the controlled substances, and as I noted before, any discarding or any discrepancy. There is an end of shift count that is also done and is documented on the inventory maintenance sheet as well. The count is typically done by 2 nurses at the beginning and the ending of the shift. When ending your shift, for any reason, if there is a note of any discrepancy in the count, it is very important to also note that we must report this immediately to the nursing supervisor so the discrepancy can be addressed. So now we look at medication errors and prevention. Medication error are breaches in standards or failure to perform by a healthcare provider that yields an unfavorable health result for the client. They are often a result of poor communication. Most common nursing medication errors include administering the wrong dose. When administered dose contain the wrong number or perform dosage units such as tablet or is 17% or less than the correct doses. Giving the medication at the wrong time is also and can be an error. Administration of a dose more than 30 minutes before or after the scheduled time of administration in the absence of acceptable reason, example NPO, diagnostic procedure, the facility schedule is the guide to correct timing, or by the wrong route is an example of medication error. When medication is administered by a route that is different from the one ordered, including wrong site, left ear for example, or right ear for example, that is also considered a medication error. Administering medication to incorrect client is also an example of medication error. Prescribing error include mistakes made by the provider in prescribing a drug. This involves unsuitable drug choices, dosing error, incompatibilities, and contraindication. Preventing medication errors. There are different ways. There are several steps we can take or can follow to decrease medication error. First, perform a medication reconciliation and avoid distraction when compiling or pouring the client medication. Next, thoroughly check the 10 rights of medication administration. Be sure to review the client data and diagnostic tests prior to administration. Finally, read the medication label 3 separate times and verify any medication allergies and or contraindication. Use the acronym PINCH to remember some or more commonly administered high alert medication. So PINCH can help you to remember potassium is a high alert medication, insulin, narcotics, chemotherapy, and heparin. Prevention steps: just follow medication reconciliation and check the 10 rights as I mentioned. Read the label and try to verify any contraindication such as medication allergies and so on. And for the uses of high alert medication, as I mentioned, use the acronym PINCH, PINCH, to remember some of the more commonly administered high alert medications such as potassium, insulin, narcotic, chemotherapy, and heparin. Of course, with everything that we do, we must do client teaching for all prescribed medication as well. The nurse must discuss and verify the client's understanding of all drug information, including drug name, dose, indication, administration guideline, and so on. Adverse reactions are harmful and undesired reaction resulting from the use of medication or other intervention. For example, chemotherapy or surgery. An adverse effect is typically a function of dosage, drug level, or drug interaction and side effects. It is also important for the client to understand that they must consult with the provider if they would like to cut or crush a medication or take over-the-counter medication such as herbal or vitamin supplements. While some of these herbal supplement does interact by decreasing the effect of the medication, so it's very important that you teach the patient to consult with their healthcare provider before taking any form of herbal supplements while they are on their prescribed medication. Finally, the nurse and the client should create a current medication list for the client reference. And it's good also for the client to carry with his on him or her when reporting to any hospital setting. So, administration technique for various medication routes. Oral medication preparation. Pour tablet or capsule into the medication container cap, not your hand. Medication prepared for unit dose may be open at the time of administration in the client's room. Score tablet, those marked to facilitate division, may be divided into half or quarter. Enteric-coated tablet and sustained release capsule must not be crushed. To pour medication accurately, using a medication cup, hold the cup at high level, then pour to the line designated the desired measured amount of medication. Volume of less than 5 ml are measured with the use of a syringe from which the needle has been removed. A calibrated dropper is used to give medication to a child or to add small amount of liquid to water or juice. Do not mix liquid tablet or liquid with liquid in the same container. Parenteral medication description. Parenteral medication are administered by way of subcutaneous, intramuscular, or intradermal injection or intravenous route. Parenteral medication. Reconstitution of injectable medication in powder form. Some medication become unstable when stored in solution and are therefore packaged in powder form. Powder must be dissolved with sterile diluent or reconstituted before use. Use sterile water or normal saline solution is used. Certain steps must be followed when a medication is reconstituted. Proper position for other routes of administration such as eye drops and ointment. When administering eye ointment, place medication. So for the drops, for example, place the medication in lower conjunctival sac and instruct the client to blink 1 or 2 times, then keep the eye closed for several minutes. For the ointment, squeeze the strip about a 1/4 inch long, unless otherwise indicated, into the lower conjunctival sac and instruct the client to gently close his or her eyes and keep them closed for about 2 to 3 minutes. in ear drops, instruct the client to lie on the unaffected side or to tilt the head towards the unaffected side and to remain in this position for 2 minutes after administration. Next, pull back the pinna in an adult client or older child. Pull the pinna up and back in an infant or a child younger than 3 years old. Pull the pinna down and back. There are other routes of administration. So for anti-transdermal patches, for example, ointment, of course you put those onto the body or the skin. You always remove the old patch or ointment and cleanse the area. To avoid touching the inside of the patch and or the ointment, you want to wear gloves. Avoid applying patches and or ointment to the skin with hair. You always want to put it in a hairless area. When using ointment, measure out the correct amount on the appropriate paper applicator and tape the paper in place on the skin if this is how it's to be done. Do not rub the ointment into the client's skin. If it's a respiratory inhaler, you want to instruct the client on how to use the inhaler. Teach the client to monitor the amount of medication remaining in the inhaler. Many inhalers medication contain no number of doses remaining in the container. So it's very important to teach the patient how to note what is left off in their container and how to monitor what the remaining doses are. Rectal suppository. To administer a suppository rectally, place the client in the Sims position. Lubricate the suppository and insert it. Point end first through the anal sphincter, about 4 inches in an adult and 2 inches in a child. Instruct the client to remain supine for about 5 to 10 minutes. Vaginal suppository. For vaginal suppository to administer, first place the client in a lithotomy position. Lubricate the suppository and insert it about 2 to 3 inches towards the sacrum. Instruct the client to remain in supine position for about 5 to 10 minutes and offer a parenteral pad if needed. So this is just to review proper positioning for other routes of medication administration as well. Went in a little bit more thorough for you. Pediatric medication administration, accurate doses calculation. So when administering medication to an infant or a child, we want to use a calibrated measuring device for this particular guideline. So oral medication are generally presented in liquid or suspension form because most young clients are not yet able to swallow the tablet. A solution may be measured with the use of an oral syringe. If an oral syringe is not available, a hypodermic syringe without the needle may be used. When the volume of an oral liquid is extremely small, it is measured with the use of another calibrated measuring device. Medication in suspension settle to the bottom of the bottle between use, so thoroughly mixing is required before the medication is poured. Medication must be administered immediately after the measurement. Oral medication are administered with the child sitting upright to prevent aspiration if the child cries or resists. Never pinch an infant or child nostril shut when administering medication. Never place medication in a baby's bottle. Draw up the required dose of an unpleasant tasting medication into a small syringe and place the syringe in the side towards the back of the infant mouth. Administer the medication slowly, allowing the infant to swallow. To disguise an unpleasant taste, mix liquid medication with less than an ounce of fluid. After administering a tablet or capsule, check the child's mouth to ensure that it has been swallowed. Some tablets may be crushed and given in small amount of pureed food if swallowing is a problem. Remember, however, that enteric-coated tablet, time-release tablet, and capsule may not be crushed. Subcutaneous intramuscular medication. Insulin and immunization are the medication most often given by way of subcutaneous route. Any site with sufficient subcutaneous tissue, example the lateral aspect of the upper arm, the abdomen, the anterior thigh, may be used for subcutaneous injection. The safe use of all injection sites is based on normal muscle development and the size of the child. The preferred muscle site for intramuscular injection in an infant is the vastus lateralis. Generally, no more than 0.5 to 2.0 ml for to 0.5 for an infant to 2.0 ml for a child is injected per site, and the site of injection is rotated if frequent injections are necessary. The usual needle length and gauge for the pediatric client range from 0.5 to 1 inch and from 22 to 25 gauge. Needle length can also be estimated by grasping the muscle for injection between the thumb and the forefinger. Half of the resulting distance represent the needle length. Pediatric doses are calculated to the nearest 100. The dose is measured with the use of a tuberculin syringe. So there's some special precautions to store controlled substance securely. Never crush enteric-coated tablet and place medication in a bottle. So drug measurement system here. The basic drug measurement systems are the metric, apothecary, the household system. Other drug measures include the milliequivalent, which used for medications such as potassium, and the unit, which is used for medications such as heparin and insulin. Blood product administration protocol. So blood product administration, when administering blood product, the nurse is expected to understand the proper identification protocol for their healthcare organization. Want to assess the client venous access, evaluate the client response, and document properly. Blood components include packed red blood cells. Packed red blood cells are given with 0.9% saline solution or normal saline. Typically administered over 2 to 4 hours. Period. Using a standard blood filter and mix cells. You can mix the cell by squeezing the bag every 20 to 30 minutes. And then platelet. Clients can experience a febrile reaction. We use 0.9% normal saline component solution with non-wettable filter. Want to give the platelet as quickly as possible. Typically 4 units per hour is given. For plasma, client can experience circulatory overload, so administer with a straight line, set and give it as quickly as possible to prevent circulatory overload. Albumin, client can experience circulatory overload as well. Use the administration set provided and give 25% albumin 1 ml per minute. Administer as quickly as possible if the client is in shock. Prothrombin, client can experience an allergic or febrile reaction. Hepatitis risk is also greater than with whole blood. Use a straight line set for the administration of the prothrombin. Guideline and safety measure for blood administration. The client must sign a consent form before the nurse administers the blood. The nurse would retrieve the blood from the blood bank area. Working with another RN, the nurse will compare the blood and the cross-match slip from the blood bank and compare the data with the client ID bracelet. The nurse will verify the client's name, ID number, blood type, and RH factors, and will also verify the donor number and expiration date on the blood container. The nurse will establish baseline data and monitor the client following the healthcare organization policy for frequency and duration. Vital signs are typically the first to change during the transfusion reaction, and it is critical to establish an accurate baseline. The nurse will record the client vital signs, oxygen saturation, and skin condition after the first 15 minutes of a transfusion. During administration, at an interval established by the healthcare organization policy, and 1 hour post-transfusion. So the nurse will record the client vital sign, oxygen saturation, and skin condition after first 50 minutes of transfusion, during the administration, and 1 hour post-transfusion. The nurse will assess breath sounds, crackles, dyspnea, and jugular vein distension. The nurse will review the client's hemoglobin and hematocrit, urine output, serum potassium and calcium and creatinine levels. The nurse will prime the intravenous tubing with normal saline for whole blood administration, and never use dextrose solution, which may cause clumping of the RBC. Make sure the insertion site is patent. Initiate transfusion slowly for the first 15 to 20 minutes and remain at the bedside with the client, monitoring the client's vital signs every 5 minutes or at an interval established by the organization policy. Frequently question the client about any unusual feeling. Most adverse reactions occur within the first 15 minutes. Benign hives may occur, and the nurse can treat the client symptomatically per policies and procedure. Now we look at type of blood donation and determining the compatibility. So to determine compatibility, client blood samples are drawn and labeled at the bedside. The client is asked to state his or her name, which is compared with the name on the client identification band or bracelet. The recipient ABO and RH type are identified. An antibody screen is performed to determine whether antibodies other than anti-A and anti-B are present. Cross-matching is performed. Donor red blood cells are combined with the recipient's serum and serum COMS-test. The COMS serum. The cross-match is compatible if no RBC agglutination occurs. The universal RBC donor is O negative, and the universal recipient is AB positive. To blood donation type. As I noted before, there are different types: the ABO, AB, O, B. These are just a list of the different blood donation for essential medical treatment, providing vital blood products to patients. Next, we look at autologous blood donation. An autologous donation reduces the risk of disease transmission and potential transfusion complication, but is not an option for client with leukemia or bacteria. So autologous is not an option for client with leukemia or bacteria. And as I mentioned before, autologous donation is the process by where a client donates their own blood for their future use. There are benefits. This method reduces the risk of disease transmission and transfusion complication. Limitation of this approach is not suitable for client with leukemia or bacteremia due to contraindication. And just some clinical consideration. Careful patient evaluation is necessary to determine eligibility for autologous donation. Blood salvaging donation. Blood is obtained to blood salvage may need to undergo washing, a process that removes tissue debris before being infused. So the overview: blood salvage involves collecting and reusing a patient's own blood during surgery to reduce the need for donor blood. Washing process in the salvage. Collected blood may require washing to remove the tissue debris before reinfusing to ensure safety and reduce any adverse effect and effectiveness. So designated donor blood. Effectiveness of designated donor blood. Infusion of blood from a designated donor does not reduce the risk of blood-borne infection. Recipient comfort. So recipients often feel more comfortable receiving blood from a donor they know and approve of. So the recipient may designate a donor or someone that they are familiar with to donate their blood, and of course that person still have to go through the screening process that is needed to make sure that there are no bacteria that is being transferred to the patient, blood-borne infection, etc. So as I noted before, infusion of blood is taken from a designated donor. It does not reduce the risk of blood-borne infection, but the recipient often feels more comfortable about taking blood from a donor they know and are approved of. Blood sampling, collection, and identification. Blood sampling collection procedure are drawn and labeled at the bedside to ensure accuracy. Patient identification verification is done. The patient states their name, which is verified against the identification band. Error prevention to prevent error in transfusion. This process ensures correct sample matching and prevent transfusion error. It basically determines the compatibility. Client blood samples are drawn and labeled at the bedside, as I mentioned. The client is asked to state his or her name, which is compared with the name on the client identification band or bracelet. The recipient ABO and RH type is identified. An antibody screen is performed to determine whether antibodies and other than anti-A and anti-B are present. So antibody screening and cross-matching. The purpose of antibody screening is conducted to detect antibodies other than anti-A and B, as I mentioned before. Cross-matching procedure involve mixing donor red blood cells with recipient serum and comb screen test compatibility. Criteria for compatible: the cross-match is deemed compatible if no red blood cells agglutination is observed during the test. Universal donors, I mentioned this before as well. O negative blood type can be transfused to any A, B, O, and RH recipient without immune reaction. The universal recipient is AB positive individual, can receive red blood cells from any AB, O, and RH blood type without incompatibility. And then the significant in transfusion is just understanding universal donor and the recipient type is critical for safe transfusion and compatibility. Now we look at preventing complication in blood transfusion. Importance of preventing complication in blood transfusion. Overview. Complication in blood transfusion can result from errors in product identification, improper infusion rate, inadequate storage, a transfusion reaction. Preventing measures for safe transfusion. So to preventing measure blood products tag, you want to ensure patients safely involved involve verifying, documenting, and maintaining blood product tag. Infuse transfusion using an infusion control device at the prescribed rate or the rate established by the organization policy. So it's very important that we utilize the infusion device that is to help control the rate and make sure that we are infusing at the prescribed rate that is established by the organization policy. Verification of blood product documentation. Accurate documentation. Carefully verify all documentation related to the blood product before administering to ensure correct transfusion and minimize risk. Keep blood product tag intact throughout the transfusion process to support the continuous verification and traceability process. Infusion controlled and prescribed rate. Use of infusion control device. Infusion control devices are ensure safe transfusion by maintaining prescribed flow rate, reducing risk of complication from an incorrect infusion speed. So whole blood and packed red blood cells, about 250 ml per unit, should be infused within 2 to 4 hours. Platelet concentration, about 300 ml per unit, should infuse within 15 to 30 minutes per unit. Fresh frozen plasma, about 200 ml per unit, should infuse within 30 to 60 minutes. Albumin 5%, 250 to 500 ml bottle, should infuse within 1 to 10 ml per minute. And albumin 25%, which is 50 to 100 ml per bottle, should infuse at 4 ml per minute. Proper storage and timing of transfusion. So refrigerate the blood as provided by the blood bank and initiate the transfusion within 30 minutes of its removal from the blood bank. Collaborate with the healthcare provider to ensure safe administration. So again, refrigeration requirements. Blood must be refrigerated as approved by the blood bank prior to transfusion to maintain safety and quality. And then timely initiation of transfusion. Transfusion should begin within 30 minutes after the blood is removed from the blood bank to prevent deterioration and complications. Collaboration with healthcare provider for safe administration. The use of autologous blood, as I mentioned before. Transfusion and pre-medicate with a steroid or antihistamine if you're going to use autologous blood. Collaborate with the healthcare provider to ensure safe administration by using this blood transfusion. And of course, as I mentioned before, pre-medicate the patient with steroids or antihistamine prior to the transfusion. The management of transfusion reaction. Immediate actions upon reaction. So notify the blood bank immediately to ensure cross-match scrutiny and closely monitor the patient for prompt intervention. Administration of calcium gluconate. Administer 10% calcium gluconate for hypocalcemia with continuous cardiac monitoring to ensure patient safety. The nurse should consider the use of wash, filtered, irradiated, apheresis, separated, or leukocyte poor blood product after transfusion reaction. So So advanced blood product option post reaction. After transfusion reaction, specialized blood products such as washed, filtered, irrigated, apheresis separated, or leukocyte poor products are considered to be minimize further complication and enhance patient safety. And then it's just basically looking at just summarizing everything, summary and best practice for preventing complication, key preventive measures in blood transfusion. Just verify all blood products, documentation, and maintain intact identification tags throughout the transfusion. Best practice is to just use infusion control device to administer blood product as prescribed by the prescribed rate, and transfusion properly after removal from the refrigerator. And as we know, we have 30 minutes.